In our last lecture, we talked about ischemic stroke, and in this lecture, we'll be going over hemorrhagic stroke, subarachnoid hemorrhage, and cerebral venous thrombosis. So intracranial hemorrhages, there are many etiologies for this. The most common cause is due to chronic hypertension. So this is not like a one bout of an elevated blood pressure, but a patient often who has poorly controlled high blood pressure over many years. And what that does is it weakens the ends of the small penetrating blood vessels in the brain, like the lenticulostriate artery. And so that weakening leads to these so-called Charcot-Bouchard aneurysms. And you want to distinguish these from the aneurysms that we've talked about before that rupture into the subarachnoid space. When we talk about Charcot-Bouchard aneurysms, the bleeding is of the penetrating blood vessels in the brain, so therefore the hemorrhage is in the brain parenchyma itself. And so there's a lot of overlap with these hemorrhages and the ischemic strokes that we just talked about. But one feature that can be a clue is you're now introducing a new volume into the brain, right? Unlike an ischemic stroke where you're just having an area of the brain that dies. Now we have an increased volume in the brain from all that blood, and so patients have symptoms of increased intracranial pressure, which remember include a lethargic, confused patient. They're complaining of a headache, they have nausea and vomiting, and we've also talked about things like a sixth nerve palsy, which can happen with increased intracranial pressure, the Cushing's reflex. So these are all things that would point us in that direction, but can be tricky to distinguish. All right, so this is a slide from Dr. Deish's lecture, so he'll be going over this as well, but here's a nice look at the lenticulostriate branches, and so it's the ends of these where we're going to tend to find these little weakenings, focal areas of weakenings on the blood vessel, and these are the Charcot-Bouchard aneurysms, and then when that ruptures, the patient is going to have a hemorrhage into the brain. So the most common location for that is in the putamen. And so let me just show you a picture and then we'll come back to the clinical features. Here's the internal capsule over here, which is normal. Here we have the internal capsule on this side. So it's lateral to the posterior limb of the internal capsule, right? So this is in the area of the putamen and the globus pallidus. And so remember, the only things that are allowed to be bright on a CT are calcium. So here the skull and the pineal gland. Sometimes a little bit of the choroid plexus will calcify normally. And so this is a hemorrhage, the other thing that can be bright on a CT. So notice that the putamenal hemorrhage, it's right adjacent to the posterior limb of the internal capsule. So you're going to disrupt the motor and sensory fibers here. So patients have a contralateral hemiplegia, hemisensory loss. And here are the optic radiations going back to the occipital lobe. So those are often involved as well. So you've got a patient with a hemiplegia, hemisensory loss, a visual field deficit, and so you might think that this is a middle cerebral artery stroke, but now we've got a patient complaining of a headache, they're nauseated, they're sleepy, confused, and may have other symptoms of increased intracranial pressure. So that helps point you in the direction of a putamenal hemorrhage. Okay, here's another putamenal hemorrhage. Again, here's the internal capsule, right? So it's more lateral. So this is the area of the putamen, and you can see that, that posterior limb is going to be severely impacted in this case. The next most common location for a hypertensive hemorrhage is in the thalamus. Okay, the thalamus has more to do with sensory processing, right? And so these patients often present with contralateral sensory loss, and as the bleed enlarges, it may extend to involve motor pathways. And so the thalamus, remember, sits right on top of the midbrain. The midbrain is important for vertical eye movements. And so a thalamic hemorrhage will often result in a limitation of the ability to look up and down. Thalamic hemorrhage has a much higher mortality because now we're exerting pressure directly onto the brainstem. Right? So Again, here's the normal posterior limb here and over here. And so now the hemorrhage is more medial. So this is a thalamic hemorrhage. So the patient's going to have contralateral sensory loss. But it's also going to impact the posterior limb of the internal capsule. And so the patient is also likely to have a contralateral hemiplegia. Okay, here's the thalamus sitting right on top of the midbrain. So that pressure is then going to impair vertical eye movements. Okay, the third most common is in the pons. And I would say this is probably the more common board question, however. When you have a hemorrhage in the pons, patients often, if you hear of someone that just, they drop dead, well, a Pontine hemorrhage would be kind of on that list of most common things to cause that. Because when you have a hemorrhage in the pons, often patients will just lose consciousness. They'll go right into a coma. If you can get the story of the symptoms they were having prior to that as that bleed is starting in the pons, they might have nausea, vomiting, headache, and maybe other brainstem symptoms that we talked about in the last lecture, like double vision, for example. So here is the board question for Pontine hemorrhage. Remember, the first limb of the sympathetic supply to dilate the pupils goes from the hypothalamus down to about C8 or T1 of the spinal cord. And so these patients have a bilateral Horner syndrome. Now, they're often in a coma, so you have to lift up the pupils, and then you see that they are so-called pinpoint. So pinpoint pupils in a patient who becomes unresponsive and in a coma is a Pontine hemorrhage until proven otherwise. Mortality here is obviously very high and close to 100% if they're in a coma at the onset. All right, so here's a Pontine hemorrhage. Okay, and we can see here the patient is not symmetrical in the CT scanner, but look at this really large space right here. This is the temporal horn of the lateral ventricle, which is very large, and so the hemorrhage here is impacting flow of CSF from the cerebral aqueduct in the fourth ventricle, and so the patient is developing here, or has, a non-communicating hydrocephalus. All right, and obviously a Pontine hemorrhage of this size is not compatible with life. Now, if our hemorrhage is in the cerebellum, so this is the least common, but from my perspective, it's the most important one for you to know about, because these are the ones that we can really intervene and save a life. And so the bleeding in the cerebellum, that mass effect in the posterior fossa, patients present with an occipital headache. Remember, anything that involves the cerebellum, there's nausea, vomiting, and vertigo. And because they have ataxia, they're very unsteady walking. Kind of along with the occipital headache, there's neck stiffness as well, just from the mass effect. Okay, and they have ipsilateral ataxia. So if it's a right cerebellar hemorrhage, they're going to have ataxia on the right side of the body. Now, if the hemorrhage is very midline and just affects the vermis, you're going to have more of a truncal, wide-based gait ataxia. So why is rapid diagnosis so critical? Well, here we have a cerebellar hemorrhage, right? So this is on the left side. The patient will have left-sided ataxia. This one's very midline, so we're going to have a lot of truncal ataxia. And so it's quite easy for a neurosurgeon to evacuate the hematoma. And so if this is very large and compresses on the brainstem, the patient can die. But if we diagnose this quickly, we evacuate the hematoma, these patients can do extremely well. So when we're concerned about a cerebellar hemorrhage, the patient needs an urgent stat head CT. Now, I told you that an MRI does a better job looking at the posterior fossa, the pons and the cerebellum, and that's true, but yet a CT is still very good for diagnosing a hemorrhage in the posterior fossa. So if our top thing on the differential is a cerebellar hemorrhage, don't waste time sending the patient to an MRI scanner. which it's going to take a long time to get the patient into the scanner. The scan time is much longer. Do a CT because we want to diagnose this and get neurosurgery involved immediately. If there's delay, then this can cause herniation and death. So why can't we operate on the other hemorrhages? Well, there is some progress being made in terms of perhaps operating on certain other hypertensive hemorrhages, but when you've got bleeding here that is in the putamen or the thalamus or the pons, you just have to go through so many structures to reach the hematoma that the surgery becomes relatively dangerous. All right, and so the cerebellar hemorrhage is really the only hypertensive hemorrhage that we can operate on safely. Now, if we have a patient with a bleed like this, so notice this is not in the putamen, it's not in the thalamus, it's not in the pons, it's not in the cerebellum. So this is not a hypertensive hemorrhage, or it's very unlikely to be a hypertensive hemorrhage. And now our differential is much broader. And so I'll never forget as a neurology resident seeing a patient with a bleed very much like this. And so the unusual location suggests we need to do a bigger workup for this. And so you may need to do an angiogram study to show that in this case the patient has an arterial venous malformation. And the bleeding was not due to hypertension. So an AVM is something important to know about. Basically, this is an abnormal vasculature, abnormal tangle of blood vessels, and the walls of these blood vessels are not normal. And so they are leaky and are prone to bleeding. Also, aneurysms are likely to form here, which is another reason for recurrent hemorrhages. So these tend to occur in younger individuals, and the presentation is usually one of two things. They either present with a hemorrhage, which is kind of catastrophic, so they're in with a new bleed, or just the mass effect of the AVM can trigger a seizure, and that can be the presenting symptom. And so patients that have arteriovenous malformation have a risk of bleeding that's about 2 to 3% every year. And treatment of this is really complex, so there are a number of things that can be done by neurosurgeons. We can try to embolize these. It's quite tricky and complex, so you don't need to know about it. But certainly if you're shown something like this on pathology, look at all those blood vessels here and the abnormal blood vessels in the temporal lobe. And so that's an arteriovenous malformation. And in this case, temporal lobe, remember, is the most epileptic part of the brain, so not surprising that seizures could be the presenting symptom. Patients that are given blood thinners, so I mentioned warfarin given for atrial fibrillation, or when we give TPA for a patient that's had a stroke, that is a risk for developing a bleed in the brain. Certainly head trauma is something else, especially if someone is on warfarin and then they fall and hit their head, then they're at high risk for having a hemorrhage. And just if you see something like this, now this looks like the middle cerebral artery vascular territory, right? And so the dark area is ischemic, but notice we have acute hemorrhage into the area of ischemia. And if you see that, an ischemic stroke with blood components, that means it's most likely an embolic stroke, like atrial fibrillation. Because what happens here is a clot went up to the middle cerebral artery, patient had a stroke, but then maybe the clot broke apart because of the increased pressure effect, and then you have just a sudden high pressure flowing into the area of ischemia, and that tends to result in some hemorrhage. So if we see something like this, we're going to look very carefully at the heart to see if we can find the source of the emboli. Now, cerebral amyloidangiopathy is where we have amyloid beta accumulation in cerebral blood vessels. This can be associated with Alzheimer's dementia. And so these patients have usually a bunch of tiny little bleeds in the brain. So the incidence kind of runs in parallel with Alzheimer's. Interestingly, so we've got the ApoE4 allele, but if you have the ApoE2 allele, remember I said those are associated with vascular abnormalities, and that would include cerebral amyloid angiopathy. So the patients have lots of small bleeds. Most of these are not symptomatic, but then finally they'll have one that is symptomatic. And so we can do a special type of MRI scan, which I don't expect you to know, and we find where this patient has had a bunch of small bleeds in the brain. Okay, and these are also a difficult management issue, but I wanted you to be aware of the condition. So trauma, Dr. Deich said the most common cause of subarachnoid hemorrhage is trauma, right? But that can also cause a subdural hematoma or an epidural hematoma. We've been over those. But also trauma, when someone has had especially multiple bone fractures, this can lead to fat emboli to the brain. And so now we get just a bunch of embolic strokes, okay? And if you do a biopsy or an autopsy, you can see the bone marrow elements here that can, and fat that can occlude blood vessels. Now, subarachnoid hemorrhage are due to these aneurysms that are called saccular or berry aneurysms. And basically, these are developmental defects in the media and elastic of the blood vessel so that the intima protrudes outward. And this is something that usually happens slowly over time, and oftentimes they're found incidentally. So someone has an MRI scan, let's say, for whatever reason, and we find an incidental aneurysm. Well, we become especially concerned when the size of the aneurysm is more than 10 millimeters. Okay, so when we're seeing that, now we're more concerned that this may rupture. So when we find an aneurysm, we do imaging periodically to follow the aneurysm and see if it's enlarging. So peak incidence is in younger patients when these rupture. It may be somewhat more likely to rupture during times of intense physical activity, like working out. That's not a huge association, but there's a little bit of a relationship there. But I would say for boards, they will often give you someone, lifting weights or doing something like that, and then they had the symptom when the aneurysm ruptured. So these are associated with hypertension, smoking, and polycystic kidney disease. I underlined that because it's high yield for boards. So we've already discussed that when an aneurysm ruptures, it causes a very intense headache. And so the locations are 90% in the anterior portion of the circle of Willis. So Dr. Deich drew this out, and I thought it was really helpful. So we can have about 30% come off the anterior communicating artery, about 30% here off of the trifurcation of the middle cerebral artery, and another 30% at the junction here between the internal carotid artery and the posterior communicating artery. That's the one that will compress the third nerve. So notice that aneurysms are much less common in the posterior circulation. And the reason is probably because there's just more pressure in the anterior circulation. So aneurysms are more likely to form as in comparison to the lower pressure vertebral basilar artery system. So patients will often come in, maybe they have migraines or tension type headaches, and they may be concerned, doctor, I'm concerned I may have an aneurysm. As a rule, aneurysms do not cause symptoms until they rupture and bleed. And so an aneurysm headache is a once-in-your-life headache. It doesn't cause ongoing, recurring headaches. And so the increased pressure, if you have a very large aneurysm that ruptures, you may have so much pressure into the subarachnoid space that can cause a brief loss of consciousness and even coma or death, like a Pontine hemorrhage. Again, may be more likely to happen while active. So because the blood now, unlike the Charcot-Bouchard aneurysms, where the bleeding is into the brain, and those patients have focal hemiplegia or ataxia and so on, subarachnoid hemorrhages usually do not have focal findings. The patient has a horrible headache, and they may have neck stiffness when they try to move their chin to their chest from stretching the meninges. The big exception is where we have a posterior communicating artery aneurysm, and that causes a third nerve palsy. Again, high yield. All right, so here's the posterior communicating artery here, and here it is over here. So it's often very asymmetrical, like we see in this case. There's the third nerve. So the aneurysm tends to form right here, and when it ruptures, then it's going to really dissect right into the third nerve. So we've got an eye that is down and out with a sudden onset headache. That is a PCOM aneurysm until proven otherwise. So in that story, we do a head CT, which is probably about 95% sensitive. And so I really want to emphasize this because I've noticed some students are under the impression we always do a lumbar puncture when we think someone has had a subarachnoid hemorrhage. And rarely do we need to do that. I mean, out of 100 patients that present with a subarachnoid hemorrhage, you would only need to do a lumbar puncture in around 5%. Okay, so we only do that if the CT is negative. Okay, so once we've diagnosed the subarachnoid hemorrhage, then the neurosurgeon is going to need to know exactly where the aneurysm is. And so we can do either an MR or CT angiogram, or sometimes a conventional cerebral angiogram may be needed. All right, and so here we can see, and I don't expect you to know what we're looking at here, but we see a little aneurysm here, one right there, small one here, there's another aneurysm there, and here we have an aneurysm at the top of the basilar artery. That's the largest one here. So this might be someone, that has something like polycystic kidney disease, where they'd be at more risk for having multiple aneurysms. All right, and here at autopsy, a large anterior communicating artery aneurysm. Here's one out at the trifurcation of the MCA here and over here. So on a CT, we look for this outlining of the midbrain here as kind of a classic feature of a subarachnoid hemorrhage. And I mentioned during the headache lecture that when we have a large hemorrhage, blood products can back up into the ventricular system as well. So treatment, we have measures of blood pressure. I mean, we don't want the blood pressure to be too high in a subarachnoid hemorrhage because we don't want to contribute to more bleeding. So there are important blood pressure, fluid management issues. Again, we will not go into. There is a medication, though, I think you probably should know, called nimodipine, which is a calcium channel blocker. And we usually give this in patients that have had subarachnoid hemorrhage. It can be helpful to prevent some of the complications that are associated with subarachnoid hemorrhage. And of course, neurosurgery is going to be involved, and we're just not going to go into how they clip and fix these aneurysms. In the third year clerkship, we will talk about the complications of subarachnoid hemorrhage. You can have vasospasm of the blood vessels, you can have recurrent bleeding or hydrocephalus. So there are a bunch of complex things that can happen in the course of someone with subarachnoid hemorrhage. Now finally we have cerebral venous thrombosis, which we have already discussed. And so remember that immediately after delivery, that's probably the most common time that we see this, there's a relative hypercoagulable state, and so women are at a higher risk of developing occlusion of the superior sagittal sinus. And even if it isn't in that setting, this still is much more common to happen in women. In some cases may be related to oral contraceptive use. And so this has a very dramatic presentation from occlusion of the superior sagittal sinus. Now you have all this pressure that backs up. And so we get these ischemic and hemorrhagic infarcts right along the midline. Okay? And so this will cause frequently headaches, double vision because you've got increased pressure that causes sixth nerve palsy. It may cause visual loss from papilledema. And with this increased pressure, you may have a confused patient. Remember, the paracentral lobule is medial, and so patients will have mainly leg weakness. Okay? And anytime you have such a dramatic distortion of activity involving the cerebral cortex, seizures are also relatively common in these patients. Okay, so remember, bilateral sixth nerve palsy is usually due to increased intracranial pressure if it comes on acutely and if it's, fits with other symptoms of increased intracranial pressure. So what do we do diagnostically? Well, immediately we would want to check a D-dimer, which is a measure of fibrin degradation. And so this is a good sensitive screening test for cerebral venous thrombosis. And then we want to do either a CT or an MR venogram. In this case, an MR venogram. We should see the superior sagittal sinus look like this all the way along its course. So here we can see we've got a thrombosis right here. Okay, so how do we treat this? We give anticoagulation, which can help to recanalize the vein right here and lead to a better improvement.